Hello, hello, hello. Utilization of health services. Chapter 13. Learning objectives. Recognize the four primary factors affecting healthcare utilization. Understand Rosenstock's and Anderson's models for utilization. Identify predisposing determinants of healthcare use. Describe enabling factors for healthcare utilization. Interest in healthcare services utilization stems from the need to assess if demand models or demand matches requirements. Utilization analysis aids in setting health insurance premiums and service planning. Providers, including hospitals and governments, conducts need for assessment before launching new programs. Government agencies evaluate patient populations to ensure adequate preventive care and hospital coverage. Tracking healthcare service utilization is crucial, especially with recent changes in U.S. healthcare insurance. With an anticipated increase in insured individuals by 2019, factors like health insurance and demographics will likely influence service demand. Utilization assessment often focuses on predictors. Demand for care doesn't always match needs, especially for the poor. Conversely, some hypochondriacs seek care excessively. Concerns about cost impact utilization, notably for non-urgent services like immunizations or cosmetic procedures. When urgent care is needed, cost becomes secondary. The patient sickness level is the main predictor of utilization. 5 major factors affect healthcare service demand. Firstly, the chosen provider type determines utilized services like physician or dental care. Secondly, location influences service use, ranging from hospitals to schools. Thirdly, the type of service, whether preventive or illness related, impacts utilization. Fourthly, visit frequently affects service use. Lastly, illness severity and required continuity of care influences healthcare service utilization. Forecasting models, akin to weather prediction, estimate healthcare utilization based on past trends. 2 main models exist, the Rosenstock and Anderson models. Rosenstock model. This model revolves around patient health beliefs influencing preventive behaviors. 4 factors predict healthcare use: perceived susceptibility, seriousness, belief in system efficacy, and environmental cues like media campaigns. While effective for preventive care, it's less accurate for urgent treatments. Anderson model. This model predicts all healthcare service utilization, considering societal, individual, and industry factors. Changes in medical technology are a key societal determinant impacting healthcare service use. Generally, advancements increases service utilization, that is technological advancements. Societal norms, evident in legislation, public consensus, also influence utilization. Technology and norms can interact, shaping healthcare service demand. The healthcare system itself impacts service utilization. Organizational aspects, like the number of trained surgeons and available hospitals, influence demand, as seen in Romer's law. Service distribution, like the higher clinician concentration in cities, affects usage, with the rural areas showing lower per capita utilization. Accessibility also plays a role. Easier access increases usage. Factors like distance, waiting times, and cost influences utilization. The healthcare service structure, such as POS or HMO plans, also affect utilization. Patient characteristics are determinants too. Socioeconomic status, age, and gender influences service use. Although poor often have lower health status, their service utilizations tend to be lower than higher income groups. The elderly and women typically use more services. Enabling factors like income and insurance facilitate access to services. According to Anderson model, illness severity is the primary predictor of healthcare utilization. This figure shows actually the individual determinants of health services utilization is pretty self-explanatory. Societal norms are often shapes laws. For instance, abortion rates increased after the Roe versus Wade ruling. State laws mandating immunizations for school entry raised vaccination rates, reducing childhood diseases. Hospitals cut post-childbirth stays to save money, prompting concerns about maternal and infant health. Congress responded by requiring a minimum hospital stay for vaginal deliveries. Studies shows that more surgeons per capita lead to higher surgery rates. Some believe this is due to necessary patient care, while others see it as doctors performing more surgeries for income. International comparisons support this trend, reflecting differences in healthcare practices across regions. Hospital admissions decreased in the early 1980s due to the introduction of DRGs, shifting procedures to outpatient settings. Length of stay often depends upon insurance coverage. Advances in healthcare have reduced hospital stays for procedures like breast cancer treatment, coronary bypass, and hip replacement. Changes in childbirth practices like increased C-sections are influenced by factors beyond medical necessity, such as cultural preferences. Caesareans delivered by race and Hispanic origin of mother, United States, 1993, is given in the figure. Factors influencing healthcare use include patient characteristics, divided into three main categories: predisposition, access to care, and illness severity. Certain patients are more likely to use healthcare services based on their demographic characteristics, social structure, and beliefs. These traits like age, gender, race, education, occupation, marital status, and residence are predisposing factors that predict service use by influencing consumer demand for healthcare. Age is not solely predictive of healthcare demand, but the elderly and young tend to use more physician and hospital service with longer stays. Elderly individuals often have higher hospital administration rates due to greater illness severity. Nursing home residents are typically over 84, 85 and often require care due to difficulties in daily activities or dementia, particularly Alzheimer's disease. Women generally utilize more healthcare services than men, except men tend to have longer hospital stays. Women have more ambulatory care visits, dental services, prescriptions, and are more represented in nursing homes. Whites typically use more physician service compared to blacks and Hispanics. Blacks are more likely to seek care in clinics, hospital outpatient departments, or emergency rooms, particularly due to residing in inner city areas with fewer private practice physicians. They are also less likely to see specialists. Race's impact on healthcare use varies when education, income, and occupation are considered. Most racial differences in utilization vanish, suggesting socioeconomic factors play a significant role. Education predicts discretionary and preventive care use. Higher education correlates with increased utilization. Children of less educated parents utilize preventive care less. Higher educated women prioritize prenatal care and mammograms. Those with higher education tend to receive preventive dental care. Occupation isn't a reliable predictor unless assessing high-risk fields like farming, mining, and construction. Any link between healthcare use and occupation likely stems from occupation's correlation with socioeconomic status. Religious and spiritual beliefs impact health behaviors and attitudes, especially for those who are ill or receiving healthcare. Studies show that religious participation correlates with better outcomes for physical and mental health recovery. Patients who consider themselves religious often have better physical health. Older hospitalized individuals who engage in religious activities and have spiritual experiences tend to have greater social support and improved psychological health, contributing to better physical health. Highly religious people tend to use more preventive healthcare services such as flu shots, cholesterol screening, and cancer screenings. Religious adolescents also tend to engage in fewer risky behaviors like alcohol use and more healthy behaviors like diet and exercise, possibly due to religious teachings against unhealthy habits like smoking and excessive drinking. Attitudes and beliefs about healthcare affect care-seeking behaviors. Negative experiences with healthcare providers or facilities may deter patients from seeking care for minor illnesses or from returning to ER unless absolutely necessary. Trust issues, communication behaviors, or racial and ethnic factors can also affect patients' confidence in their primary care clinician. Conversely, those who believe symptoms require immediate attention may seek care sooner. Health beliefs and education strongly influence the use of preventive healthcare services. A mother's health behavior can impact their children's behavior. Satisfaction with past healthcare experiences predict future use of services. Divorced or widowed individuals use more health services compared to married people. Marriage is associated with lower mortality and suicide rates, as well as fewer risk behaviors. Married individuals generally have better mental and physical health, with married men benefiting more than women. Poor marital relationships can negatively impact health, leading to issues like depression and unhealthy habits, affecting various physiological systems. Health often declines due to bereavement or divorce. Patients in medically underserved or economically distressed areas face higher risks. For example, those in medically underserved areas have greater risk of late-stage breast cancer diagnosis, despite the high success of early detection treatment. Residents with poor access to primary care also face increased risk of late cancer detection. Even though inner city residents may be close to academic health centers, they are more likely to lack insurance and seek care from non-physician providers. People in economically distressed communities face greater danger from risky and violent behaviors of neighbors compared to those in wealthier areas. Victims of gang violence, shootings, drug-related incidents, assaults, and rape are more likely to live in less affluent areas. Unfortunately, treatment for injuries from such incidents is often urgent and may be life-threatening for the victims. Enabling factors facilitate access to healthcare services, wealth, health insurance, location, and provider availability influence healthcare access. For example, having a well-paying job with health insurance increases demand for healthcare. Lack of insurance or part-time work without coverage affects access to healthcare. Living in urban areas near prestigious medical centers can also improve access to quality healthcare services. Patient wealth affects affordability, especially for expensive treatment not covered by insurance. The poor are more likely to be hospitalized and have longer stays. Surprisingly, a higher percentage of blacks in poverty have a usual source of care compared to whites. Having a usual source of care increases healthcare use, but poor individuals are less likely to have one. Health insurance enables patients to access to healthcare services. Before Medicare and Medicaid, physicians' visits increased with income, but with these programs, visits decreased with income as the poor had coverage through them. Poor individuals use more services because they are generally sicker. However, having insurance doesn't necessarily promote healthy behaviors, but rather encourages seeking therapeutic services. People with insurance generally use more services than without. The availability of hospitals, clinics, and doctors in an area impacts service demand. Short wait times for appointments and in offices or ERs can increase service consumption, while longer service travel times decreases it. However, patients may travel for serious issues like cardiac care. Location also affects beliefs and customs around healthcare consumption. So physician supply and price as enabling factors. More doctors means more healthcare use, illustrating Romer's law, which suggests more hospital beds leads to more days spent in them. This phenomenon reflects induced demand, where doctors can boost service demand that patients wouldn't otherwise seek. Physicians can influence demand to some extent. The price elasticity of healthcare is generally inelastic, but preventive or elective services are elastic. Elasticity measures the percentage change in demand divided by the percentage change in price. Elastic demand, elasticity greater than 1, means demand is responsive to price changes. Inelastic demand, with elasticity less than 1, indicates less responsiveness to price changes. The most significant predictor of healthcare demand is illness severity. It can be assessed through patients' self-reported health status, with those rating their health as fair to poor more likely to use physician services. Illness severity, whether perceived or diagnosed, determines the utilization of hospital, physician, and dental services. People who are sicker or have greater disability tend to use more healthcare services. The various factors influencing healthcare utilization affect the entire delivery system. The ER services as a barometer for the system strength and efficiency, with failures reflected in its utilization. Many uninsured individuals rely on ER as their primary source of care, leading to complex and costly treatments. System failures contribute to overcrowded and strained ERs, worsened by limited access to other facilities, financial barriers for the poor, and provider shortages. Hospital financial challenges results in staff reductions and premature discharges, increasing ER visits and readmissions. Economic crisis, including hospital closures and reduced insurance coverage due to unemployment, exacerbate the situation. Physicians offer visits in various settings like private offices, hospital clinics, ERs, by phone, and through HMOs and private clinics. House calls are rare, but phone consultations are becoming common. Most Americans visit physicians in their offices, with around 75% seeing a doctor at least once a year. Inpatient surgeries are decreasing, while outpatient surgeries are rising. Despite technology moving many procedures out of hospitals, average length of stay has stabilized at around 6 days. This decline is due to technological advances, changing norms, cost concerns, or reimbursement changes. Unless major technological advances occur, the average length of stay is unlikely to change. Studying healthcare utilization ensures patients' needs are met, influenced by the system and personal factors. Provider shortages limit access, especially in remote areas. Wealth barriers are offset by health insurance, but it's unclear if this disconnect from healthcare costs lead to optimal outcomes. Insurance helps sick patients afford care, but may encourage risky behavior and delay preventive care. Technology has improved access, reduced costs, and enhanced outcomes, but its unchecked use and cost-cutting measures can affect results. Healthcare practice variation allows clinicians to generate unnecessary demand, as Romer's law. So this ends the chapter 13, which focuses on the utilization of health services. Please remember to read the textbook closely and get more details. Most importantly, keep smiling This is Dr. V signing off. Thank you.